It is my great honour as ISTG President to introduce our Bosco O'Mahony lecture this year, which will be delivered by Professor Deborah McNamara. Professor McNamara is a Consultant General Surgeon in Beaumont Hospital, Clinical Professor of Surgery at the Royal College of Surgeons and co-lead of the National Clinical Programme for Surgery, as well as being Member of Council here at RCSI. She chairs the Rectal Cancer Leads Group of the National Cancer Control Programme and the RCSI Committee for Surgical Affairs. She is a strong advocate for surgeons and surgical patients. In her role as co-lead at the NCPS, she works with colleagues in all surgical specialties to develop and publish implementable evidence-based policies and care pathways that improve the delivery of surgical care in Ireland. Her talk today is titled Finding Your Tribe. So, Professor McNamara, I welcome you to the podium. Thank you very much.
It's been a fantastic session, thank you, and thank you very much indeed for just the complete privilege of giving this lecture. Everyone wanted to know what the title was about. I'm not sure the title necessarily is what the lecture's about, so we can figure that out. I'm just waiting for my slides to come up, and I'll be good. Okay, I might just go through and move on to the next slide first. So it's a real honour to give this lecture in honour of Bosco O'Mahony. There are not many Irish surgeons who are known by one name. If you think about it, there are probably just Bosco. He worked in Wexford General Hospital. He trained all over the globe. He worked in London, trained in Harvard, worked in the Brigham and Women's. President, he even trained in St. Vincent's. He was a very talented surgeon. And he chose to spend his life in Wexford. He brought his family there. He delivered an outstanding service to the people of Wexford. And he made a difference in people's lives. He made Wexford the best place in the country to train to be a surgeon and to begin your surgical career. And I think that speaks volumes about him. So I'd like to step back and think about what is surgery. And it's a bit philosophical, I know, so bear with me. For those of us in this room, surgery, well, it's a profession, isn't it? It's something that, it's a community, it's something that you have decided to do. It's something that you've dedicated probably every waking hour for more years than you care to think about to becoming a surgeon. And for the trainers in this room, it's something that we are committed to help you become. It's something that we want you to be able to do. We want you to join the community of surgeons. We want to teach you how to cut like a surgeon. But more importantly, we want to make sure that you think like a surgeon. And maybe it's old-fashioned to call it a vocation. But if I were to ask most of the people in this room what they were, I don't think they'd say, I'm a doctor. I think they'd say, I'm a surgeon. And when we pick up the phone to another surgeon, or we meet them at a conference, no matter where we are, we have an awful lot in common. And so the process of training in surgery really is also a process of professional formation. It's a process of developing that professional identity where we make that transition from the sort of aspirational hashtag, I look like a surgeon, to the very much less glamorous being a surgeon, which is not what it looks like on social media. And it's something in which we join a long line of surgeons over centuries in delivering care to people. And it's one in which we make a commitment to deliver training to the next generation of surgeons, the people who follow us. But sometimes we need to step back. And when we step back, we realize that outside our bubble, outside this place, outside our operating theatre, surgery is actually a service that people need. And that's a need that we are not meeting well at this time. more than 350,000 people in our country are waiting to see a surgeon, waiting to come to one of our clinics. 250,000 of them are waiting for more than a year. And that list is getting worse and worse. I have the pleasure of working in the National Clinical Programme in Surgery with really talented people who are trying to fix this. One of them is Jerry Kelleher, and he analyses this data for us. And it really tells a very compelling story of the problem that we face as a profession. And as you all know, seeing us in the clinic, that's just the beginning, because then they wait for tests and they wait for surgery. And this is the October 2021 data. More than 71,000 people are waiting for a surgical procedure. And they're waiting for a very long time. 1/4 of them are waiting more than a year. And I know you're all frustrated hearing this. We had really good debates about it this morning. You know, the health service is in a place that none of us, I think, can say that we're truly proud of. And I suppose you're facing those frustrations every single day when your list is cancelled. You can't get a patient in. We heard about begging a bed manager to get a bed. So we're facing these frustrations and these delays in care. What you might not realise, though, is that of those people, 2/3 of them are waiting for something that's actually fairly ordinary. So they're not waiting for massive operations, and they don't need a robot. They need a scope, or they need a minor op, or they need an ambulatory procedure, or they need a day case. So 2/3 of people are waiting for something that we're not actually spending an awful lot of time thinking about, I think it's fair to say. And so when we look at that, I think that's quite striking, where we're devoting our energy and what people actually need from surgery as a service, as opposed to surgery as a profession. And what's even more interesting to me, and something you might be surprised about, is that half of people are waiting for just one of just 15 procedures. And I don't mean to be disrespectful, but they're all pretty ordinary procedures. And really, there's not a good reason why we can't be doing these procedures, because there are people who are waiting for very complex surgery, and they need hospital beds, they need lots of resources, they need robots, they need fellowship-trained surgeons, and that has to happen, and we want to deliver that care as surgeons. But there are also people waiting for lots of ordinary things, and we also need to look after these people. So I think there's this fundamental conflict that we face between what we're able to do and what we can actually do in our workforce. And I suppose, for me, that mismatch is actually very corrosive, because there's a social contract between surgeons and their patients. And we make a commitment that we're going to deliver surgical care, and by and large, we really do want to do that. And that mismatch is really obvious to young surgeons. And I think it's part of the reason why people are emigrating in droves, because they feel this disconnect between what they're trained to do, what they want to do, and what they're actually able to do. So for me, I think we are at a crossroads. And I think that everyone in this room has a decision to make, because despite being dedicated to our craft, our health service is just not delivering the service that our patients need. And so I think that we need to think very carefully about what we are going to do about that. In 2019, Professor Ian Robertson, the Emeritus Professor of Psychology at Trinity, gave the Carmichael Lecture across the road. This was pre-pandemic. And you can still access it. I put the link there. Hopefully you won't be accessing it during my talk, but if you want to look at it later, you can take the QR code. And he talked about the different types of human responses that when we're faced with a challenge that we might encounter. So he talked about apathy. So when we're faced with a challenge that we don't believe we have the skills to deal with, and even if we did, we feel like we couldn't do anything, apathy is a response. And he talked about anger. And anger being a response when we do have the skills that we need to do something, but the circumstances are stopping us from using those skills. And as he spoke, those two ones at the top there, apathy and anger, they really resonated with me, because by this way of thinking, they're really expected consequences of the incredibly challenging circumstances of our health service. And they're also really tricky to escape. And I think that ultimately they could be quite disruptive and quite destructive of us as people, because it's easy to get stuck in these reactions and to think that everything is just terrible. There's nothing we can do. And I have seen that happen to people over and over again. And I'm sure you've seen it happen to people. And I suppose one thing that he talked about I thought was much more positive, and that was talking about this state that he called activation. And one sentence that I put on the slide that I took away from his talk was his description of what distinguishes human beings from every other species. Human beings, he said, imagine things that do not exist and work to make them happen. And that state of activation really, really resonated with me because, in fact, it's the cornerstone of healthcare quality improvement. And that's an area that I've had a huge interest in for many years. So I do think there's a gap in our mindset as surgeons. And that gap, I believe, is making us more vulnerable to things like apathy and anger. And I suppose, let me explain why I think that. So this is the improvement equation. And this has been designed on years of expert work about how to deliver healthcare quality improvement. And so just to run through it, it tells us that if we want to improve a measurable improvement in performance, then we need to have and know the evidence. We need to understand the context. We need to know how to apply the evidence to the context. And we're not too bad at all that. So like most experts, when you complete surgical training, when you complete specialist training, you're going to have really deep knowledge in the domain of evidence. So you're going to know the data, you know the literature, you know the technical details, you can do the procedure. So as our experience increases, we have all that evidence, we have all that knowledge. And then as you get more and more experience, you start to implement that knowledge, that evidence. And so take the example of a laparotomy. So you know the indications. You can do the operation, and you can probably teach someone to do the operation. And as you get better on it, you can do the operation even though the patient's on NOACs and no one told you. Or you can do the operation even with a scrub nurse who's very inexperienced. Or you can do the operation at 3 o'clock in the morning when you would much rather be at home in your bed. So we get really good at implementing our evidence into a context. And our training gets us that far. But say you discover that the outcomes of the operations that you're doing aren't as good as they should be. Say you discover that the post-operative care your patients receive is not up to scratch. We have the audit cycle, we memorize it, we cite it at every interview that we do, and that tells us there's a problem. How do we fix the problem? And I think where we're completely lacking in knowledge is about how to operationalize that change. And so that can be an enormous source of frustration because we have a really clear idea of what should happen and possibly no idea of how to make it happen. And so for me, figuring that out, I think, was something that one of my mentors helped me with. Unfortunately, I'd been a consultant for about 10 years at this time, but I got a phone call from Frank Keane, Professor Frank Keane, and he said, there's this quality improvement course going on, and I really think you should do it. And I don't know if he saw in me the anger and the frustration of not being able to do things I wanted to do, or if he genuinely thought it was a good idea, but in any case, it was really a life-saving intervention for me. It's probably dramatic to say that, but it opened a window for me into tools that were to prove enormously helpful to me over the next decade of my career. And I suppose what improvement science and studying that over the last 10 years has taught me is that improvement science is about the how. Because mostly we know all about the what by the time we finish specialist training. We know what should happen. We know how care should be delivered. But we don't really know how to get it done when it's not happening. And so for the first 5 years after I did that course, I was in a huge flurry of enthusiasm and set up a healthcare quality improvement learning collaborative in my hospital. We called it Better Beaumont. And if I can tell you a slightly funny story, I recently was involved in some work in Cork, and they've decided to do one too, but they're going to call it Better Than Beaumont. So I thought maybe that meant we made an impact. But during that work, I learned really two important lessons that for some reason I hadn't really captured in my training. One of those was the value of collaboration. And I suppose one of the first people for me that collaborated on this work was Dr. then and Professor now Fidelma Fitzpatrick, who's recently become chair of microbiology here in the college. And she just came to the meetings. She didn't actually say much, she didn't do much. She came to the meetings and she got a few more people to come to the meetings. And she supported me in doing that. Without her, I couldn't have done it. And we led this together for the whole period, really up until the pandemic, when you weren't allowed to go to small rooms anymore. And so I think collaborating with people who are in that activated state, in that state where they're trying to make things different, I think that it was a really impactful thing for me. And the other one was the value of incremental effort. You don't have to fix it all today, but understanding tools and methodologies that can help you fix big problems over time in a coordinated way with like-minded people is the only way our health service is going to change. I think it's a fabulous idea to throw it all up in the air and start from scratch, and clearly that would be the best thing to do, but that is not going to happen. And so we can only work through incremental change and make lots of small changes that are going to add up to those significant impacts. And over the years since I've become involved in this area, I've worked with many of you on different aspects of this and different ways of looking at this. So from Peter Lonigan doing a fellowship and looking at problems in urology and how we can deliver ambulatory care better, how we can communicate with patients better, to Deirdre Nally, Emer O'Connell, and many of you in the audience who worked on the Know the Score project with us, trying to improve our use of scoring mechanisms to do better assessments of our emergency laparotomy patients. To Jessica Ryan, looking at what the barriers are to doing day case lap chole. And most recently, a project that we're working on through NCPS, Transforming Theatre, working with 10 hospitals across one hospital group, trying to understand what are the barriers to using our theatres efficiently, and to my great surprise, discovering that there is some capacity in our theatres across the country. But it's not necessarily where we think it is. I was really struck during the debate thinking about people not being happy with 1 day a week theatre time. And I agree, that is not adequate to deliver all the care you need. But when you look at these problems, you don't need really a very high-tech hospital to deliver this care. But you do need surgeons who are prepared to think differently, who are prepared to engage and deliver this care to patients in the way and the place that they need it. And so actually now, having spent probably the last 10 years of my career really being interested in quality improvement, learning about it, learning about implementation science, now when I look at waiting lists like this, you know, I'm not very happy about it for sure, but I'm not filled with despair. Because now when I look at them, I see a series of problems to be solved. I see a puzzle. I see something there's a solution to, something we need to break down, something we need to figure out, lots of small solutions instead of one big, massive solution. And that's where you come in. Because imagine what could happen if we put our best minds, your minds, to fixing healthcare. You are our greatest asset. Imagine if you thought about fixing healthcare as much as you think about your technical performance of surgery or your research or where you're going to go on your fellowship. So putting our best minds into fixing healthcare is really the challenge of your generation. Imagine what could happen if we were able to collaborate and share knowledge about fixing healthcare better. If we could connect the questions that we have, connect the answers that we have identified, and try to build together a network that connects really the pockets of excellence. There are brilliant examples all across the country. It's one of the amazing things in the clinical program. You get to meet people who really are still working incredibly hard to make our public health service a better place. And if all those small pockets could be connected, I think that would make an enormous difference. And I'd like you to just imagine what would happen if we really just accepted the massive upheaval that we've lived through for the last 2 years. And if we tried to figure out a way to deliver the services that patients need, to do the operations that we want to do, but maybe do it in a different way. Not expect the health service to deliver 2 theatres in a perfect week. Maybe looking, how can we try and address this? How can we put our minds to fixing this problem? And I use the example from our COVID era. You know, I think for most of us here who've worked in the health service for a period of time, if you'd asked us in 2019, would we identify a new disease, design a vaccine, and administer 10.4 million doses of it to people in Ireland in 2 years, I would have said you were mad. But yet we did it because we had no option. We did it because our best minds made sure it happened. And we had the operational capacity to make that happen because it was important, because people made it important. So I think we can do extraordinary things. And I suppose thinking through that 2-year period, so many of us developed a different way of living, a different way of looking at the world. And I'm really taken by this idea of Carlos Moreno, who's a French Colombian professor. And he talks about this amour de lieu, which is your attachment to a place. And we're a great emigrant nation. But I think over the last 2 years, I certainly have had a much greater appreciation of my own country, perhaps, and all of the hidden gems that we have, and all of the things that we should be doing better, because what we're doing now is just not working. And I do know that without all of you putting your mind to it, that transition is not going to happen. So I think there needs to be really quite a step change in how we deliver healthcare, surgical care for the patients. So I would say to you that we are at a crossroads, and each of us in this room has a decision to make. Do we just keep throwing our hands in the air and say, the healthcare service just can't be fixed? Or do we join together, try and imagine a way that we could make it better, and really put our collective effort into realising that ambition? RCSI and the National Clinical Programme in Surgery are going to continue to advocate for career structures that will attract and retain our higher surgical trainees to be consultant surgeons in Irish hospitals. Last year, the NCPS worked with hospitals and hospital groups to approve 56 consultant surgeon jobs. 35 of those are new. So there are jobs, and they are good jobs, and you can make them better. Because you're the future of our health service. We cannot expect you to do it alone, and we need to support you. You need to build your own networks. Sometimes you will need to be a leader in this work, and sometimes you'll need to be a follower in this work. But here, when I think of this, I actually think Bosco, because he and so many other surgeons in his generation, you know, he was 35 when he went to Wexford. And although he died far too young, he really achieved amazing things in that time. He built a team, he made a home, he made a difference in his community, and you can do that too. Change in the health service does not happen overnight. But if you're persistent, it can happen. When I was appointed to Beaumont in 2003, we were the first hospital in Ireland to have a second coloproctologist. Seems extraordinary now that you would have hospitals with only one coloproctologist, but there you are, that's how it was. And now I work in a team with 5 others, and we work across a region, and we're working together to try and improve rectal cancer services in our region. And I think we'll do it. And when I look around me at Beaumont, and there are many other hospitals, consultants from other hospitals in the room today who could tell me the same stories about their hospital. But when I look at Beaumont, I'm surrounded by people who started just where you are now, who put their shoulder to the wheel and who decided to make things just a little bit better. So we have cochlear implantation because of Laura Vianney. We will open a breast cancer centre because Arnie Hill and Deirdre Duke made it happen. We've got a great transplant centre. The best ward in our hospital is our transplant ward. And that happened because Dilly Little made it happen. Surgeons are people who get things done. We need you to get things done for our health service. So I would just finish with this. You are our most precious resource. You can hop on a plane and leave us to our crumbling health service, or you can make the hard choice. You can stay, and you can make it better. Thank you.